hello everyone. My name is Darinda Sutton. I'm a Vice President and Chief Nursing Officer for the two of our segments of clients across the U.S., what we refer to as Premier and Foundation. And I've worked for Cerner for 14 years, and I have been in a nurse exec role at Cerner for probably 13 of those 14 years, and cover basically all of the U.S. and the majority of our clients. So one of the things that and just to give you an idea of my background, before I became an informatics nurse, my bedside clinical background is ER, open heart ICU, and I did quite a bit of dialysis. So I think that often we see a lot of critical care nurses migrating to informatics. So let me go ahead and share. And hopefully everybody can see my screen. So I'm going to talk about the ECD, as we are calling this, the Essential Clinical Data Set. And the history of this is we started this collaborative, or identified that we wanted to work on defining what the Essential Clinical Data Set is back in 2016. So as all of you, I'm sure, are struggling with the era of optimization, I think that's the new era that we're in, we have found that many organizations over-design their EHRs. There is a lot of noise and just a lot of value-added or non-value-added data elements. So as I was working with a lot of our organizations who were longtime clients, some maybe, you know, they were only live maybe 2 years, but they had really over-designed and overbuilt their system. And as a lot of organizations were independently looking at optimization opportunities of how they could get rid of the noise, what I was finding is that there was no established standard for what was really the essential data elements that need to be documented in an EHR. And some people will say, oh, but what about the, you know, the nursing minimal data set, and we have all of these data standards that we're trying to map to. But we do, but there was nothing that was really focused on what is the content that should be documented by a nurse in the EHR. So we started this, and just like many of you and your organizations have nursing executive imperatives that you work on, that was one of the imperatives that the Cerner nursing executive team identified in 2016. And at that point, I was sort of voluntold that, yeah, that's going to be the one that you're going to take care of and figure that out. So that was how I got into all of this work. It's been exciting work. And when we started this, you know, I was looking in the literature for something, maybe a blueprint or some methodology that some other organizations had done around this, and really couldn't find anything. So a lot of the work that we did at the beginning was to really map out what is a methodology, how are we going to approach this in a manner that could be replicated not only across different segments of our patient population, but our intent was that this might actually serve as the foundation for a national, and as we're learning, even an international standard for what is needed to be documented or what's essential in the EHR. And I want to just highlight that it was very intentional that we use the word essential, because as you know, there is a minimum data set. There is a nursing minimum data set, and I didn't want anybody to confuse or construe that we were trying to do something like that. So that's why it was very important for us to actually use the word essential. So we were finding it across our client base, and then we also knew that this was an emerging US agenda item from an informatics perspective. And at that point, Rebecca Friedman was actually the CNO of ONS, or ONC, I'm sorry. And you know, she was talking about some of the joint work of the ONC and CMS to really minimize the documentation burden for clinicians. And I think many of you are probably familiar with some of the documentation and some of the national committees and work groups that are focused on decreasing the burden of documentation. But within that, there was also the goal of trying to achieve some type of standardization of documentation from a nursing perspective. So we knew it was a U.S. national agenda item. And out of some work that happened in 2017 at the national level, the ANA and the ONC created the documentation burden standardization and the care planning virtual work group. Some of you on this call might be on those. I think we have monthly calls, but we have also joined that to provide some input into the work that they're doing. And then as I was starting to work or get feedback from some of our organizations in different countries, we also found that, you know, this is a global problem. It's an international problem. I actually had the opportunity last May to go to Vancouver, Canada to present to a national conference, and I presented some of the initial work that we were doing on the essential clinical data set. And the Canadian Nursing Informatics Association and the Canada Nurses Association published a joint paper also looking at standardizing the nursing documentation across Canada. And then we are also doing some work with Australia and found out about a position paper that their nursing informatics group posted, and these were both in 2017, about the adoption of a nationally agreed upon standard. So you can really see that, you know, it's not just us in the US that are struggling, everybody is struggling, no matter what EHR you have. So what did we do? We brought together a group of clients that were interested in the topic of optimization, standardization of nursing documentation. So here you can see the clients across the United States. And I just want to back up a little bit to, in order for us to have a scope and guardrails around the scope that we were looking at, we started off with, this collaborative was focused on the med-surg adult patient. And we then also looked at, there were 8 core clinical workflows, as we sort of refer to them. And we broke those 8 core clinical workflows into 6 work groups. And we had 12 clients. So we had 2 clients co-chair each one of those work streams. To give you an example, the first one that we worked on was the adult admission intake assessment. Another one that we're just finishing, I'll give you an update on, was the adult physical assessment. We also did some initial review of literature on transfer and discharge, the whole medication process, plan of care. So you get the idea of what some of those work streams were. But we identified that we needed to start with the adult med-surg. We had to put scope around it so that we could actually get something finished. So this was the group of 12 clients that we brought together. And then, as I said, there really wasn't a blueprint that we found in the literature. So this was something that we had to really define ourselves. We knew that we wanted to do something that was evidence-based. So we're really calling this, it was a 3-pronged approach. The first one was evidence-based practice. And we needed to clarify that we were looking for content, not process or workflow. So I think that all of you know that when you do a review of the literature, you'll find a lot of articles that are written and published around a particular workflow or a particular process and how to go about doing that. But there's not a lot out there that is solely focuses on the content and the what that needs to be documented. So that was our first prong, evidence-based around the content. We also knew that we needed to really be cognizant of the non-negotiables that we were around regulatory. And we focused on the federal regulations. So CMS, Joint Commission, DNV, what was needed for meaningful use 1, 2, and 3 at that point. So we were looking for US federal. We typically do not go to the state or local level. It gets a little bit complex to keep track of 50 different state and then, you know, how many different local and county regulations that you might have. So that is something that we look to our client organizations to really understand what their state level regs are if they need to adjust it. And then last but not least was practice-based evidence. So when I showed you the map of the clients that were included in our collaborative, we had probably accounted for about 160,000 patients. And we felt that that was really needed in order to validate some of the practice-based evidence that we were using. So I'll show you a little bit about how we went about doing that, but just as a high level, what we did is we extracted, so for each one of our members of the collaborative, we got their permission to extract 3 months worth of data. And the data that we extracted was around how they had their system built. So what were their questions, what were the electronic forms and the electronic documentation that they used for the adult med-surg patient. The second piece of data that we extracted for 3 months worth was the utilization, so that we could, with some of the data that we can pull, and we have some things sort of factored into our software, we could extract the data that allowed us to understand what was the utilization of a question, so that we were able to identify which clients had what questions, and then we could look at the frequency of how often that was actually documented within a 3-month time period. So all of those 3 prongs and that approach culminated in the definition and the development of the final essential clinical data set. So I'm going to take one pause right there and see if there's any questions about any of that to date. Are you tracking with me so far? It's not really brain, it's not really, brain surgery once you understand how we went through it. It's just a matter of organizing the people and the time to do it. So I'm not going to go over this in detail. You guys will have access to the slides, but just to be able to give you a high-level overview, we started the kickoff. We identified who all the members were, and we started that in June of 2016. We got on a WebEx just to be able to go through what our methodology was, and we also wanted to provide an opportunity for all of our collaborative members to have an 8-hour regulatory session, and we actually contracted with an independent consulting company that specializes, they're all nurses and they specialize in consulting for CMS, Joint Commission, and DNV. So we use them as an external independent consultant to help us with the regulatory review. We had our work groups go through the review of literature for the evidence and to synthesize that around the content for all the workflows. We then had a regulatory review. Then we did some report outs, we did some data extraction, and then we started on the collaboration and simmering all of that information to define the essential clinical data set. And then here you can see that it took us into July of 2017, so a year later, to sort of finalize that definition. And then we had our first 2 clients go live with the adult admission intake assessment in November of 2017. So it seems like it took us a long time to get through that just for adult admission, but what we were able to do is the process that we identified, we are able to replicate that across many other ECD initiatives that I'll share with you at the end of the session. But just to be able to validate the variation that clients had. So here's 11 of our 12 clients. This was their baseline data for their adult admission intake. So I think that a lot of organizations have interwoven assessment data, initial measurement data into their admission history. So one of the things that we looked at was if there was something that was really focused on the physical assessment and some of the data capture of measurements, we said that is something that we want to move to physical assessment so that we keep that whole. So there wasn't this commingling of the first physical assessment into the admission assessment. But that's what you'll really see here reflected on the numbers. You can see client number 6 came out as our winner, and I guess that's not a good place to be at this point. They had 13 different electronic forms that had 57 different sections and almost 1,000 questions. Think about that. This is what they had for every one of their med-surg adult patients. Now, I will also want to point out client number 9, who only had 1 electronic form, 21 sections, and they were already down to less than 200 questions. That was probably one of our largest organizations that was part of the collaborative. And the other thing to note is that they were a for-profit organization. So if any of you work for a for-profit organization, you know that there's probably tighter control over standardization. So this is where we started from, so that added validation to the work that we needed to do. And then knowing that you guys are informatics nurses and want to get into the nuts and bolts of how did you actually do this, I'm going to share just a couple screenshots of our main tool that we used was Excel. So when we extracted the data, what we did is we had each client validate their data to make sure that we had extracted everything out of their database of everything that they do on admission. And then what we did is started to create an Excel spreadsheet that was the client comparisons. So on the first column, there's a couple different categories that we have on admission. This just happens to be, quote, the general category. And then the question, and the first 2 columns actually came from the standard content that at that point we were releasing to any new client that wanted to have it. So then we cross-mapped every one of the clients. Here you see client 1, 2, and 3. But they actually went in and said, okay, chief complaint is the same question as reason for visit history. So we did that crosswalk of the questions that each client had. And then from that, we were able to really apply an algorithm. So again, there wasn't a blueprint, there wasn't anything that was in the literature. So what we agreed upon across the collaborative was that if 8 of 12 clients had that question, asked that question, so that's the frequency column, column A, and because we pulled utilization data, we knew how often that question was actually being completed or documented against. So we wanted a frequency of 8 of 12 clients, but we also wanted the utilization average of those questions to be greater than 60%. And our thinking behind that is that if nurses feel that asking a question and documenting it is valuable and it adds value to the work that they're doing, then they're probably going to answer it. So that was some of our hypothesis around creating this frequency and utilization algorithm. So once we had all 12 clients compared and we sort of had their data normalized, we did the frequency and utilization. And so in order for us to define the final essential clinical data set, we went through our 3 prongs. So the first one was evidence-based. Does anybody want to take a guess on how much evidence we found around the admission content that should be collected on the admission intake by a nurse? 0. There wasn't anything out there that we could find that needed to be collected from an evidence-based perspective. When we got to regulatory, that was a different, there were things that we did need to either comply with CMS Joint Commission or DNV or some of those meaningful use measures. And then the practice-based evidence was where we used this frequency and algorithm. And I just want to make one other clarifying comment. The 8 of 12 facilities and greater than 60% utilization did not automatically include it in the ECD. That just put it on the list to have clinical critical thinking applied to all of those questions to say, does this really need to be collected by an RN on admission? So just to be able to give you a visual, this is where we actually use electronic forms, typically for our admission history. Here you can see where we were before and all of the scrolling, then the sections that you have on the left-hand side. And then after we were finished, we were down to just a handful of sections. So we removed 13 sections from our standard content that we were releasing, and we also got rid of 167 distinct questions. So what were some of our key findings and considerations? Well, one of the things that we found was that the senior nursing leaders and the CNOs have to be involved in this process. So some of you might be sitting there and saying, well, this is something that if you give me what the ECD is, I can just do a crosswalk of what we have today, and we can go down through that checklist, and that would be the ECD. Well, when we had a couple clients do it that way, they were like, well, we can't get rid of this. We can't get rid of this. This is something that we've always done it this way. And we really found that the senior nursing leadership needed to be involved to help really drive the intent of why we were doing this. We were breaking down those urban myths and really getting to the why. So we found that obviously a nursing shared governance council was best suited for the review of the essential clinical data set, so that we'd have the nurse execs help outline what their vision is and help set sort of the guiding principles. And those shared governance councils being led by nursing informatics has been our most successful format that we've seen. In the workshop that we have people do to just do the admission history comparison, we really needed to challenge the group that was brought together because we've always done it this way. So asking 5 times. And some of the other key principles that we used for admission was, number 1, did it need to be collected on admission, yes or no? So, and then if the answer was yes, then we said, is it the RN that needs to collect it, or is there another member of the care team that would be better suited to collect it? So those were some of our questions that we were really pretty rigorous in asking. We also found many organizations had policy driving practice. So their interpretation of what a regulation was really driving how they had designed their system. And when we got clarification on what that regulatory item really was, they were able to say, okay, well, you know, they're sort of constricting their own practice and their own staff because their policies were a little bit more vigilant than what they really needed to be. Local critical thinking and a judgment was applied, but what we've really found as well is that the process of an organization going through this from a nursing documentation perspective was just as valuable as the outcome of having very streamlined documentation for nurses. So how did we fare? This just gives you an example of 15 of our clients. So we looked at what their baseline was, how many questions they had, and pre and then after they went through the ECD localization, as we're calling it. So what you can see here is, you know, on the left-hand side, client A had almost 650 questions. And again, it just, you know, it sort of breaks your heart because it's like, oh my gosh, that all the issues that we hear about the burden of documentation and those kind of things is just playing out in some of these numbers. And you can see some of the after numbers that we've had with organizations. Now, one of the questions that you may have is, so if we have identified what the essential clinical data set is, then why are the green bars in, you know, different, why do they differ so much? So it looks like out of this sample of clients, our sort of lowest number after is 43 questions. I will tell you that that is a cancer specialty center, and they were gung-ho on getting rid of all of this non-value added stuff. And then it looks like 150 questions is one of our high ones. But remember that the organization needs to look at what any of their state requirements are, but any of their local requirements from a regulatory perspective. But then in all honesty, there's some of these organizations that have been up on their EMR for 10 or 15 years, and they had some very sophisticated rules, clinical decision support that was tied to several of these questions. So as we work with each organization to do their analysis, one of the other things that we really looked at was, what is the secondary use or the downstream use of any of these questions that we're getting rid of? And that was also a very eye-opening exercise for many organizations, because I bet you that every one of you can sit there and think, oh, well, I would bet that, there's, X number of questions on our admission intake. They absolutely are driving a decision support rule, or they're being displayed somewhere. And it was amazing to find how much stuff we had in there that we thought was doing something, and it wasn't going anywhere. So it was just something that was done on admission, and who knows if anybody ever went back to it. So this was our success and some of our outcomes that we've had from our adult admission history. And then just to be able to give you a little bit more perspective, some of the other things that we've been able to, the metrics, so we've identified some standard metrics that we have that we can pull for baseline and then post-go live across the different venues or the different ECDs. So we talked about the total questions. On average, they're reducing about 100 questions out of their admission assessment. We can also measure time with some of the timers that is in our software. So the total time on average was reduced about 2 minutes and 21 seconds. So it may not sound like a lot, but think about your, busy surgical unit or your med-surg, one of your medical units that's turning over, 10 to 15 patients on an evening shift, and the number of how much time that is. And then just everybody's always looking at the number of clicks. So we've also on average reduced at least 37 clicks out of this. So that is the adult admission. So we had great success with that. I think that as of today, we probably have close to 30 or 35 clients that have actually taken the med-surg adult admission history into their production environment. Once we identified the success that we had with that methodology, I had another one of my team members, we started last year, to form a pediatric collaborative. So we have a PEDS ECD, and this just gives you an idea of the scope. And I know, Artie and Andrea, you had mentioned about Boston Children's. Boston Children's is actually one of our organizations that's part of the Pediatric ECD and some of the work that we're doing there. So with PEDS, you can see we were basically following the same process. They are focusing on admission history and intake. That was just finalized. They're going to be kicking off physical assessment very soon, and then ongoing care. They followed the same guiding principles. They also pulled in some of the pediatric, the ANA pediatric scope and standards, and the American Academy of Pediatrics as two of their sources of evidence for the practice and the content that they're using as well. So this just gives you an idea of the pediatric organizations that we pulled together for the pediatric ECD, and we wanted to make sure that we had not only freestanding standalone children's hospitals, but that we also had children's hospitals that were part of larger IDNs. So there you can see the makeup of that collaborative. This again will give you a timeline. We kicked off PEDS in January of 2018, and by the end of 2018, we were able to define what the pediatric admission intake was, and we've had our first couple clients go live, and I'll show you those outcomes in a second. But similar to what we saw with the adults, the PEDS had some of the same variation, with the number of questions from 100 to 720 for your, and this was basically your PEDS, your PEDS admission, not your NICU or your PICU admission. And then the average number of sections and questions that were on those intakes. So here again is a before and after. So on the left-hand side is where we started. This would have been our standard content that anybody would have taken as a new organization. So 35 sections and 359 questions. And that got simmered down to 12 sections and 83 questions. So a few more than the adult, but there was a lot of those growth and development areas that they needed to account for. So this gives you an idea of what the outcomes were for 3 of our clients, and they just went live the beginning of March. So you can see that 2 of them had, about a 50% decrease in the number of questions. I will tell you that the 3rd client is a pediatric specialty hospital, more around musculoskeletal and orthopedic diseases and admissions. So that is why theirs is probably a little bit higher than our other two PEDS clients. But, you know, just being able to get a 50% reduction, you can almost feel the, you know, some of the weight of the nurses on the nurses' shoulders decreasing. All right, so after we finished the adult admission, the next one that we felt was going to be even more impactful was going to be the physical assessment or review of systems. So one of the things that we had to start with was actually define what systems were going to be part of this. And, you know, some people might, you know, chuckle a little bit at that. It seems a little bit silly. But as we were starting to look across our different organizations, we were finding that what they were including in their review of systems and the body systems that they were identifying was just off the charts. So we really wanted to make sure that we were narrowing that down to true body systems. So that's where we focused on. And again, here you can see the number of assessment items, you know, that we had for the physical assessment, and basically just the review of body systems. So again, great variation. And then to sort of cut to the chase, on the left, you can see where we started with our standard content that would be available. And then on the right-hand side, we actually narrowed that down to 14 sections. So we do have each one of the body systems, and we decided to pull out specific sections for vitals, measurement, pain, you can see that, and then some of the scales at the bottom, the Morse-Fall or the Braden assessment. So where we ended up was, with our final design, is we started off that in our standard content, or model content as we refer to it, we started off with almost 1,700 questions, and we actually trimmed that down to be about 1,000. And then out of those 1,000 questions, we also did a leveraged very heavily conditional logic. So basically what we did is we looked at each one of the body systems, and we identified and looked at what are the, you know, 3 to 5 questions or assessment things that need to be assessed for that body system for a general med-surg patient that, regardless of what their admitting diagnosis is. And then based on what those assessment items were, we adjusted the assessment question so that we could leverage conditional logic, so that you had like either a yes or no answer, it was present or not. If something was present, then the conditional logic would open up the next question so that it would take you down through a tree to document against. We had a lot of discussion about that around our brand new nurses, a nurse that's new to an organization, or some of our GNs that are becoming new nurses. Would they know what to document? And one of our hypotheses as we start to move this live is that with the conditional logic and being able to decrease the number of things that are face up. So again, if I go back to this screen, you'll see how many things are face up. How does a new nurse know what's important and what's not important? You know, this is where I think we've just added so much noise and complexity. So if a new nurse or a graduate nurse has just the question or the sections on the right-hand side, and we have specific questions, like 3 to 5 for them to answer, that will guide them down the path to ensure that they're documenting what's appropriate. So we're anxious to be able to get some field testing back on this, which I'll give you an update in just a second on that of where we're at. So there you can see, you know, where we're at, just getting rid of some of the non-value added things. The other thing that I had mentioned is we did want to make sure that we had some standard metrics that we could have the organization get their baseline and post go live. So we had, from a qualitative perspective, the collaborative created I think for admission, it was a seven or 8 questions. We wanted to keep it short. So we are sharing those assessment questions to any organization that is working on the essential clinical data set so that they can get the before and after of what the nurses impression is of, before and after related to the admission. And what we've also done for the physical assessment, we actually created 2 different assessments, one to do for the RN population of before and after, but then we also felt very strongly that when you're reducing all of this noise out of a physical assessment, the people that are trying to find the information, who may not look at nursing documentation now, that they may see an impact. So not only your providers, I'm not sure that they would, some of them may do a survey, but like your social workers, your case managers, your rehab therapists, your respiratory therapists, if they're trying to find something, we believe that by decreasing the amount of noise and just having the essential clinical data set for review of body systems is going to help tremendously. So we also created a survey that can be administered pre and post to your non-nursing care team as well. And then on the quantitative side, you can see some of the general things that you would probably expect us to look at, the distinct number of questions before and after. We're looking at active time in, around documentation. We can do that down to the user level. Clicks, single sign percentage. So what that really means is with the admission assessment, we were finding that nurses were going back, more than one time to complete the admission assessment because it was so long. So we also found some impact that by shortening the admission intake assessment, that nurses were able to complete that in one setting so that they didn't have to remember to come back and keep opening that up and redoing that, or continuing to answer questions. So that gives you an idea from a metrics perspective what we have outlined as part of the collaborative that we're including in all of our ECD work as well. So wanted to give you a recap. So I'm leading the Adult Med Surg Collaborative. So we have finished the adult admission intake. We have 30 clients live. We have in October, we were able to finalize the physical assessment ECD for Med Surg. And then we identified, there was 11 clients that were interested in being in the initial cohort to compare what the physical assessment ECD was to what they currently had in their production environment. So we did joint working sessions from October through the end of December to go through it, and we broke it down by body system so that it was chunked it out a little bit. And by the end of December, we finished that review. Excuse me. And we've had 2 organizations start to phase in bands of this, but tomorrow, I was telling Artie when I got on the call that I'm actually sitting in Oklahoma right now, and I will be flying out of Oklahoma tomorrow and going to up to Maine. We have a large health system up in Maine that has 9 hospitals, 8 of them on our EHR, and they are rolling out the adult physical assessment across all 8 of their hospitals. So I'm going up there to do rounding at 4 of their hospitals to see how the physical assessment is going. From a pediatric perspective, the admission intake is defined. I told you that we have 3 clients that are live with that. And I know that in April, we'll be kicking off the pediatric physical assessment to follow the methodology that we did for adult physical assessment. The other thing that we will be working on is a pediatric observation intake, and also, that autocorrects to per-op, pre-op surgery intake. So that's another ask that we've had across organizations to really look at our pre-procedure, pre-admission testing workflow for the intake perspective. We have another one of my regional clinical executives is leading a behavioral health collaborative, and they're going to be initially focusing on the behavioral health intake assessment. And we have not only standalone behavioral health organizations on that collaborative, but we also have IDNs and community hospitals that have a strong behavioral health population. So the intent is that the behavioral health intake will work for clients and patients, whether you have a primary or a secondary diagnosis. We have also completed an adult observation intake assessment. I think we have 2 clients live with that. And then we're also working on an adult pre-op surgery intake. We have an adult critical care collaborative that is going to be kicking off next month. So we're going to be taking what we did for the med-surg, and then we're going to start off with sort of the CCU and CVICU, what's needed for those 2 areas, a med-surg ICU, and then a neuro ICU, I think are the first 4 that we're going to tackle. And then the other thing that we're kicking off in spring will be related to women's health and OB admission intake. So there was a lot of questions that were shared between the adult med-surg intake history and women's health. So we've already done a review of those. So if we took it out in the adult, we're going to take it out in women's health. And then there'll be a subset of the admission intake questions related to women's health and the laboring patient that comes in. So we'll be kicking that off in the spring. And then just to be able to share with you, I started off that this is really an international and a global issue. Based on the meeting that I presented last May, there was one of our hospitals that in Vancouver who worked on a Canadian essential clinical data set. They actually went live in December. And there's another organization on the east coast of Canada, Prince Edward Island, that is going to also begin to do some collaborative work, and then they're going to bring those together into that joint collaborative that I mentioned that the CNA and Canadian Nurses Informatics Association was working on. We've also had very strong interest from Australia. I have had 2 planning calls with some people in Australia who are members of the National CNIO Council that is driving the standardization. So we're working through some initial planning of what their charter is going to be, what their scope is going to be. But again, they are adopting all of the methodology and the starting point of what we did from a US perspective. And then probably about 3 weeks ago, I had the great fortune to be able to go over to London and the UK and present to a conference over there. And we have organizations that are interested in the UK to put together their collaborative. And again, taking what we had already, some of the initial work that we had already done as a launching point, and then just adjusting that to what is needed from a UK perspective and the NHS as their national health system. And also the Middle East, they are very similar to what we do in the US. They typically don't change a whole lot of what we do from a content perspective, so they're keen on starting their collaborative as well. So that sort of gives you an idea of how we started off with, okay, well, let's just define what we need for adult med-surg admission. And we have had such tremendous feedback from our organizations and the people that we've presented this to that it's just grown, and it has really become the methodology that we are creating our content from within. So with that, I know that I went through that fairly quickly, but I would like to absolutely open it up for questions, comments, reactions. What do you guys think? Does it make sense? What do you think?
I'm going to unmute everyone, so just give me a second, Darinda, please. Get my participants. And I think you have to unmute yourself. So I'm allowing everyone to talk, and then you can unmute yourself. So there have to be some questions. Darinda, I just thought this was so cool. And, I actually worked at a Cerner site as an ICU nurse for, per diem, just while I was still working full-time in informatics just trying to stay current with clinical. And that was one of my biggest pet peeves was, oh my gosh, it takes so much longer to chart now.
Mhm.
But, you know, you have done an amazing job, you know, getting to the essential clinical data sets. I have a question if nobody has one right off the top of their head. Have you done any studies to find out if there's been any, couple things, improvement in patient outcomes, first of all? And second of all, have you done any nurse satisfaction surveys?
Yeah, so let me answer the second question first. The surveys that I was talking about that we created for nursing, we have had almost every client do a pre and post, and the nursing satisfaction and just what they think about it has just been phenomenal just after just doing the admission history. So we have quite a bit of data on that. You know, one of the things that I'm struggling with, so, you know, as Andrea was going through the students and placing students in practicums, if you have any students that need a project, we're looking, you know, we would love to be able to do some cross-client analysis on some of not only the patient satisfaction surveys, but, or the, you know, nurse satisfaction surveys, but some of the other data that we have. So we're working on getting all the data scientists together to do that body of work. Your first question about impact to patient outcomes. You know, that has been something that we've talked about, and conceptually, we would really like to be able to figure out what would be those outcome measurements that we could tie back. So remember, what we have live today is mainly around our admission intake. So it was kind of difficult, and we didn't really find a good measure of what patient outcome would be impacted other than patient satisfaction, and you're not in my room, you know, for 45 minutes asking me questions while I'm not feeling well. So that's something that we struggled with admission. Now with physical assessment, one of my organizations that is going live very soon is really looking at the impact on pressure ulcer documentation and present on admission. So
Right.
we're trying to, so that's going to be one of our quality patient outcomes that's going to be part of this for that particular organization, so that we can see, you know, has there been, you know, an impact to the documentation on POA, so that they, you know, that's all documented.
Very cool. And we do have a couple of questions in the Q&A box. Jewel Mendoza says, this is fantastic. How are you sharing your US findings with non-Cerner organizations?
Yes, so great question. Well, first of all, I have to tell you that I'm trying to get this published. I've had 2 rejections, so I guess that builds character when you're trying to get things published. And, you know, we're still working to get this out in the literature because, you know, I think, so that's one thing. But what are we doing to get this out to non-Cerner organizations? So the invitation that I had from you all to be able to share some of this, a client colleague of mine, we actually presented at HIMSS. We had a podium presentation at HIMSS down in Orlando a couple weeks ago. The other thing that we've actually are doing, so we actually have 2 clients that are on Saurian clinicals, and they are starting to go through the analysis of what the data elements are to put that into their Saurian system. And then we've also had a large national health system that the majority of their hospitals have our EMR, but they do have a couple hospitals on Allscripts on their inpatient, and they have actually implemented this in their Allscripts hospital. So we're trying to, you know, sort of get this out into some of the, you know, with some of the national conferences. And then I am actually going to be attending the Big Data Conference. That is going to be, you know, it's hosted by the University of Minnesota in June. So we'll be there as part of that as well.
Excellent. Yeah, I want to go to that actually.
Yeah.
So another question from Paula Walski. What the overall impact is for areas that are doing research. I think about the amount of data that is collected on a regular flow sheet and how much information is collected that way.
Yeah, so, I'm glad that you asked that question, because I actually had a nursing researcher from one of my organizations sort of push back on this. And she said, Darinda, right now we just have this plethora of information that we have at our disposal to, any research question that we may have, we can pull out information. And while conceptually I don't disagree with her, I just think that there was just so much noise. There was so much arbitrary things that you didn't have a lot of standard completion of to even get a full data set to be able to pull. So, I don't know what the overall impact is going to be from a nursing research perspective. And, whether or not by trimming down and just having the essential clinical data set, if that's going to hinder any of downstream research studies that are going on or not. But, I think first and foremost, I'm, and this might be blasphemy, but I'm more concerned about our bedside clinicians and reducing their burden and helping them take care of themselves, because we see, not only the burden of documentation, but, if you guys have started to look at what the % of nurses are that are burnout, oh my gosh, it's just sad. And we're going to be losing them as we get into even more nursing shortages. So I'm probably selfishly more concerned about our bedside clinicians and really reducing what they need to do and making it meaningful for them. I don't know if that answered your question, or if you have a follow-up question to that.
Not sure if Paula does.
I don't know if you can hear me, Artie.
Yes, I can.
Okay. I wasn't sure if I unmuted myself correctly. I think the reason why I asked that question is, you may know that we implemented Epic probably just about 4 years ago. And when they created the assessment flow sheets and whatnot, they did it with the idea of a minimum data set. And it is a lot of content, some of it regulatory, some of it not. And when you have a large system that has multiple facilities involved with the creation of the EHR, there's things there that are particular to academic medical centers and things that are not particular to community medical centers. So it's just curious to me, because I believe we created our system the way we did with research in mind.
Mm-hmm. Yeah, and I suspect that there's probably a lot of organizations across the country that did that. Some of the academic organizations with that research thought in mind. But I guess I would go back and maybe just ask the question, so all of those things that you've put in there, are you actually using them? And maybe it was part of a research study, 4 or 5 years ago. Is that still a valid study? Because I think sometimes we lose track of how the data ages. And, oh yeah, it was put in there, and then it becomes that urban myth, and you sort of forget, what the true intent was.
I appreciate that.
Great. And we have a couple more questions that are coming in. And Mary had a few. She had to sign off, but she sent me some questions as well. Barbara Jones says, as a Cerner client, where can we find the essential clinical data set? This is great work. So
hi, Barbara. Yes, I saw your name on the list. Hello there. So we have this, so the admission history for the adult is part of Model Experience. So it's out on our Model Experience Wiki. And Barbara, you can send me an email directly and I can get you information on any of the other collaboratives that we have content available for. So if you want to do PEDS admission or observation or adult physical assessment, I can get you the Cerner workbook that we have for that.
Great. And I just wanted to respond to your response to Paula about the research and that kind of thing. And I noticed during your presentation, you did make a point that each individual client had to review everything and make sure that, you know, they had what they needed. And maybe had to add some things, as was prevalent in your bar chart, because some clients, you know, were way down here and others were way up here.
Yeah.
So that's a good point too, is that it's very individualized, but to start with the essential clinical data set is fantastic. Another question, Delwyn, have you done a time motion study after implementation of the ECD?
Yeah, so we have not done a specific time motion study, but one of the things that we have available that is part of the Cerner, that's embedded within the Cerner software, are what we refer to as timers. So we can actually pull data out of the system, and every client, every one of our clients, so Barbara would be able to do that at Kent. She would be able to pull out data to see how much time nurses, and we can break it down by category of nurses. Nurses are spending in documentation or orders or finding a patient, chart review. So we have about, I think, 16 or 17 categories of work that the nurses do, and we can break it down by category, and then we can also break it down to the actual nurse. So that is, we're able to automatically extract that data so that we can look at what the time in EMR and the clicks in EMR, what the difference is pre and post. So we did not really need to have anybody spend the time doing a specific time and motion study with a stopwatch. So it was much more efficient, and it's measuring the same thing across all of our clients. So it's a little bit, we think it's probably more valid.
Great. And Delwyn's following up with one more question. What is the ROI for Cerner for doing this work? Wow.
The ROI. So I don't know. I think it's not really what Cerner is getting back at all. This is not anything that you know, any of our organizations can go and, you know, do this. And, you know, as we mentioned, we want to be able to begin to share this outside of the Cerner community. We are not getting, you know, extra money or, you know, getting profits off of this. I think it's really adding evidence and practice-based evidence back into our industry, and really helping to identify, or not even identify, that the problem's already been identified, but to maybe offer another option as a solution to decrease the burden and to really, you know, help our bedside clinicians. That's what it's all about. That's what it's in for me. You know, I didn't know what I was getting into in June of 2016 when I said, oh, sure, I'll take that initiative. Or that imperative. And it's really been very rewarding to just see the acceptance and, you know, just how organizations have embraced this. It's just been phenomenal. I've not really seen something like this in my nursing career be so quickly adopted by some clinicians. So the ROI is personal satisfaction.
Absolutely. It's the fourth leg of the quadruple aim, right?
Yeah, that's right.
Hello.
Yes.
Hi, it's Delwyn. So I just wanted to say that it's very it's good to hear that from a company, that you care about your the experience of your users, and you're not just after the bottom line. So I commend your company for doing this effort and not expecting any in return, because I don't know of other companies who would take such an enormous project and not seeing any return of investment. So just wanted to say kudos to you guys.
Well, thank you. Thank you. Yeah, this really has been a labor of love. And if I think about how much, and the commitment of our client organizations that have been involved in this has just been stunning. You know, when I started to look at organizations to say, hey, you want to start doing this in the beginning of 2016, and they're still sticking with us. We still have that adult collaborative working, And I think we might have lost one client that they said, you know what, this was a little bit too much. But just the strong professional practice investment that they're making has just been phenomenal. And we couldn't have done it without our clients either. So, you know, and so I appreciate, Dylan, your comments. That's it's very humbling, and it's something that we take to heart, that we really do care about our patient experience and our staff experience, I should say.
Well, if the nurses are satisfied, so are the most likely, so are the patients, right?
Yep, that's right.
Mary had another question. She wanted to ask if you focused on any streamlining of any specific nurse-sensitive measures, such as pressure injuries or falls, or has that already been done?
Yeah, so what we did as part of the physical assessment work is, you know, the number of selections that you have for, you know, and the typical one that we always use is color of urine. Some people have 40 different colors of urine in there. Does it really matter that it's light yellow, pale yellow, tan yellow, you know, all those kind of things? So when we looked at all of the assessment items, we also looked at what are the answers that we are providing for nurses to select as their assessment items. And we've cut that down a little bit, but specifically around the nursing quality measures, we had already adopted as our standard Braden. Now we have some organizations that use other pressure injury scales. And then we also have already adopted, as part of our standard content, the Morse fall risk. I know that we have some clients that they elect to, you know, their standard is something else. So we had already had that decision made. But I will also tell you that the other thing that we did include in the adult admission assessment was the Columbia Suicide Scale as part of the initial screening for suicide. And we did add that as a standard that was then released to all of our organizations to use as well as a screening tool.
Great, thank you. Does anybody else have any questions? I think Mary had one more question. Did non-value added data collection move to others? I don't know what she means by others. Like collecting data on clothing and jewelry patients bring in on admission.
Oh, the eternal valuables question.
Belongings, yeah.
So we've had, you know, if I had the number of hours in my career that I've debated and had a conversation about valuables, it's amazing. But we talked about that in the collaborative, and I think we elected to not have it, but many organizations have kept that back in. But I think the question really is, when we were asking, does it need to be collected on admission, yes or no? And if yes, does it have to be the RN? There's two examples that I'll share with you of things that we pulled off of the admission intake. And then I'll give you some examples of things that we moved to other parts of the other people to collect. So two questions that we had historically had on our admission intake was one around transfusion history, and then the second one was around anesthesia history. So think about 15 years ago, when probably some of our content started to get organized. Think about how many patients we were probably transfusing 15 years ago, and how many patients were probably going to having surgery. So we've reduced the number of inpatients having surgery. You know, we're putting them through outpatient, and we're also reducing the amount of blood products that we're using. So we had these two questions on admission history. Now, if we think about it, number one, it really isn't the nurse's responsibility for collecting some of that. It really should be the provider, as they're making the determination of whether or not the person's going to go to surgery or they're going to get a blood transfusion. So we felt that it was not in the scope from a nursing perspective. We wanted to also look at, you know, who was everyone documenting at the top of their license. So we took those off of the admission intake and felt that at the point that that patient was going to go to the OR or that they're going to be transfused, then that should be the point that we look at some of those things. So those were two things that we took off. Now, there were some questions that had been historically on the admission intake around, oh, I'm blanking on some of them, but it was really around some of the demographics that are typically collected from a registration process that we said, we already have the registration clerk collecting some of this. That is not something that an RN needs to collect. And I think, I'm going to say, I don't know if, I can't remember where we landed with religion, but, you know, some of those, you know, local pharmacy or something like that, like some of those types of things that aren't necessarily the RN's responsibility, many organizations push that upstream to their registration clerks. So that's an example from the admission history, some things that we moved to a different department in some organizations. But then there were other organizations that once they went through their workshop to do the cross analysis, there wasn't anything that they had to throw over the fence to another care team member to take. Is basically, you know what, we don't really need it. So did that answer your question? That one, I think, maybe it was Mary.
Yes, it was Mary's question, but yes, I believe that it did move to more appropriate people.
Yes, and there wasn't a lot of it though. It was either eliminated or moved to the most appropriate place.
Right. Great. Any other questions?
Hi, it's Andrea. I just had a quick question. So I know you talked about nurse satisfaction. We're not really sure about that, but I'm curious about nurse productivity. Do you know if by chance there was any decrease, maybe incidental overtime or just like HPPD overall at any of your sites?
You know what? We have not looked at that specifically, but we have several of our organizations, actually the organization that I'm going to up in Maine, they have a staffing and scheduling and acuity system that is being used. And that would be something that we would be able to pull out of their database related to the physical assessment, because I think that's where we're really going to see our impact with physical assessment. So that's a great question, and something that I don't know that we have thought about from a physical assessment.
Thank you.
Yeah, that is a good question. I mean, if you can prove that for your clients that, you know, they're saving money on overtime,
right,
through their documentation, it's a win-win. All right, anyone else have any questions? Okay. Well, I don't hear anyone else. I would like to thank Darinda.
Yeah, thank you so much, Darinda.
I know. It's very exciting stuff that you're doing and stuff. Isn't that a professional term?
Yeah.
But I think it's very exciting. And, you know, as a nurse, I'd love to be at the bedside again and be able to have a different experience.
So I did put my Twitter handle, and I'm probably more of a LinkedIn person. So if any of you want to connect with me on LinkedIn, I'd be more than happy to have you follow me. I'm going to, when I'm up in Maine and we're going live this week with the physical assessment, I'm probably going to do some tweeting and doing some posts on LinkedIn to let everyone know how it's going. Or you can, if you want to reach out to me by email, I'd be happy to do that as well.
Great. Well, thank you so much, Darinda, and I appreciate you making time in your day and from Oklahoma to share your information with us. And we're kind of exploring this theme of documentation reduction. Our journal club, which is next Thursday night, we're doing a virtual journal club, is about an article on reducing documentation as well. So join in for the NENIC members. If you haven't signed up for the virtual journal club next Thursday night, it's on the website. And Darinda, thank you so much again appreciate your time and your information. It was just fantastic. So,
Well, thank you for having me, and thank you for your interest in the topic. We've just been super excited with the work that we're doing and happy to share it. So thank you.
great. We appreciate it greatly. So thank you.